So with that, enough of my yapping. I want to introduce the highlight of the morning. We are thrilled to have the CMS Administrator, Seema Verma, join us this morning. Seema is, I can run through her lengthy bio, but I think you all know she is actually the 15th Administrator of CMS. To my knowledge, she is clearly the only one who has come into the job knowing a lot more about Medicaid than Medicare, which I think is, it's about time. Because we've long known what, CMS has 1M. We've known what that 1M really was. We're hopeful that 1M is Medicaid now. I've actually known Seema from actually way back in the mid-90s. From back when I was working with the Medicaid Directors, which seems like eons ago, and she was with ASTO, the public health officials, and we've kind of intersected over the years. She is a nation-renowned expert on Medicaid issues. She's the architect of the Healthy Indiana Plan, an expert on helping get states through the Byzantine 1115 waiver process. She is here today to share her vision, the administration's vision for Medicaid and what is next for all of us. So with that, I would ask you to join me in welcoming Seema, and we're glad to have you.
Good morning. It's truly a pleasure for me to join you today, and it's great to see so many familiar faces. So when I was first nominated to be the CMS Administrator, I was told if I wanted a friend in DC, I should get a dog. Well, I have 2 dogs, but I left Bono and Luna back in Indianapolis. So you guys are going to have to do. But seriously, it's really good to be here among not only familiar faces, but many friends. I and everyone at the Centers for Medicare and Medicaid Services truly understand the importance of the Medicaid program. It makes an incredible difference to millions of Americans. But behind every statistic is a life, a face. Individuals like Richard, a gentleman I met in Indiana. He's paraplegic, but when we were passing the Healthy Indiana Plan, he showed up with his caretaker to hearings and other meetings in a bed that carried all of the equipment necessary to keep him alive. It wasn't easy for him to come, but he felt strongly about making sure that the Medicaid program was providing high-quality health care, and speaking on behalf of beneficiaries was something that was so important to him. I also have a colleague whose sister Christy has both autism and epilepsy. The severity of her condition requires her to receive 24-hour care, and a Medicaid waiver makes it possible for her to receive that care in her home. For people like Richard and Christy, Medicaid is more than a safety net. It's a lifeline, one that needs to be preserved and protected for those who truly need it. This is not only about caring for our less fortunate citizens, but doing what is possible to help ensure that none of them are left out, left behind, or left on the sidelines of the American dream. For all of Medicaid's recipients, we work to provide for the best quality of life possible that works best for them. Whether it be seniors living in the community through the support of personal care services or the respite care that allows a parent to keep their child with a disability living at home. We have a higher purpose than just handing out Medicaid cards. The Medicaid program is a promise to help individuals live up to their highest potential, leading healthier, more fulfilling, and more independent lives. Medicaid is central to our promise to the American people, and it's a promise that we at CMS and President Trump care deeply about. And it's a promise that must be refitted and renewed for each generation. We fail to live up to that promise when Medicaid merely provides a card without care. And that's why we're ushering in a new day for Medicaid at CMS, not closing the book, but turning the page and starting a new chapter. For those of you who don't know me, I have worked in the trenches of Medicaid for many years, working side by side with states to help them reform and strengthen their programs. I've shared the hopes, fears, and trust of countless Medicaid recipients, as well as their families and caregivers. And I've seen the difference it's made in the lives of people like Richard and Christy. And I am deeply committed to this program. However, I have also seen that our safety net should be stronger to ensure that no deserving Americans fall through the cracks. We must, and we can, serve them better. The challenges are great, and so must be our solutions. When the federal government established the Medicaid program, it was intended to be a partnership between the federal and state governments to care for society's most vulnerable citizens, with both jointly contributing towards the costs. The relationship has changed over the years, and I wouldn't describe the current status as a partnership. With Medicaid being an open-ended entitlement, the program has grown and grown, and states have spent more and more. In 1985, Medicaid spending consumed less than 10% of state budgets and totaled just over $33 billion. In 2016, that number had grown to consume 29% of total state spending at a cost of $558 billion, diverting state resources from other areas such as education and economic development. And with increased state spending came increased federal spending, which naturally meant increased federal oversight and regulation, and more regulation. Today, the federal government reviews and scrutinizes every single decision dictating how the program is run in so many aspects. As an example, the state of Nebraska recently reviewed its original Medicaid state plan, and it was only 17 pages. Today, that agreement is thousands of pages long. However, despite our growth in spending and in regulations, more than 1/3 of doctors won't even see Medicaid patients. And as the roles have greatly expanded, it has led to longer delays, longer travel times, longer waits for care for those who rely on the program. Not only is this unacceptable, it puts increasing burdens on some of our most vulnerable populations, people like Richard and Christy. To paraphrase Hubert Humphrey, the moral tests of any government is how it treats those in the dawn, the twilight, and the shadows of life. Our vision for the future of Medicaid is to reset the federal-state relationship and restore the partnership, while at the same time modernizing the program to deliver better outcomes for the people we serve. It's what I believe we all want. We have an obligation to help those who need it most, and we need to ensure we are building a Medicaid program that is sound and solvent and helps all beneficiaries reach their highest potential. In order to accomplish this, we are focused on 3 areas: flexibility, accountability, and integrity. And first, let me discuss flexibility. We are a diverse country, and that diversity gives us strength. But New York doesn't have the same challenges as Mississippi or even Alaska, a frontier state that has to fly patients to receive even routine care. No 2 states are alike. The delivery systems and needs are different. When I was working on behalf of states, I never designed the exact same program twice, because every state had different ideas, different needs, and different challenges. And that's why Washington shouldn't design a cookie-cutter Medicaid program. Instead, we need to respond to this diversity by empowering states to work with their communities, their providers, and citizens to design a program that meets their diverse needs. As we turn the page in the Medicaid program, CMS wants to support states in their efforts. We want you to create innovative programs for the people you serve, because we believe you know what is best. Past administrations haven't always respected this diversity and instead imposed a Washington knows best, one-size-fits-all Medicaid policy. And maybe that's why Medicaid has faced problems for decades: problems with access, problems with quality, and problems with program integrity. And rather than fixing these problems, the Affordable Care Act just put more people into the program, further exacerbating the issues and jeopardizing care to our most vulnerable citizens, the population that the program was originally designed for. The ACA moved millions of working-age, non-disabled adults into a program that was created to care for seniors in need, pregnant mothers, children, and people with disabilities, stretching the safety net for some of our most fragile populations, many of which are still on waiting lists for critical home care services, while states enroll millions of newly eligible able-bodied adults. The ACA also gave a higher federal reimbursement than they do for our most vulnerable citizens. If the match rate is a reflection of the value we place on caring for our neediest citizens, this is backwards. And while many responded to this expansion with celebration, we shouldn't just celebrate an increase in the rolls or more Medicaid cards handed out. For this population, for able-bodied adults, we should celebrate helping people move up, move on, and move out. We have a moral responsibility to do more than just give them a card. We have a responsibility to give them care. The thought that a program designed for our most vulnerable citizens should be used as a vehicle to serve working-aged, able-bodied adults does not make sense. But the prior administration fought state-led reforms that would have allowed the Medicaid program to evolve to meet the needs of these new individuals, and they did this, even when increased coverage was at stake. Before becoming administrator, I experienced this firsthand when I worked with states to adapt to the ACA. When designing waivers, I found that many states wouldn't even put their best ideas forward because they assumed they would be rejected by Washington. Those days are over. We are resetting the partnership between the states and the federal government, and that work has already begun. I am pleased to announce several initiatives today that demonstrate our commitment to supporting states and innovation. But before I do that, I want to take some time to thank my Deputy Administrator, Brian Neal, and the entire Center for Medicaid and CHIP Services for the amazing accomplishments and progress they've made in such a short amount of time. They are truly dedicated public servants and care deeply about the Medicaid program. Thank you for your service. Today, the CMS website contains new information for states about our expanded vision of what types of projects can achieve Medicaid's objectives. As you know, demonstration projects offer an avenue for states to pioneer innovative approaches that deliver local solutions to local problems. In support of this, we want to make sure the lens through which we view proposals is clear and responsive to the requests we have received from states. One of the things that states have told us time and time again is that they want more flexibility to engage their working-aged, able-bodied citizens on Medicaid. They want to develop programs that will help them break the chains of poverty and live up to their fullest potential. We support this. As Medicaid has expanded to able-bodied individuals, the needs of this population are even more imperative. These are individuals who are physically capable of being actively engaged in their communities, whether it be through working, volunteering, going to school, or obtaining job training. And let me be clear to everyone in this room, we will approve proposals that promote community engagement activities. Every American deserves the dignity and respect of high expectations. And as public officials, we should deliver programs that instill hope and say to each beneficiary that we believe in your potential. For the future of our country, we need all Americans to be active participants in their communities. Currently, the labor force participation rate for men 25 to 54 is lower than it was during the Great Depression. To maintain continued strength of the American economy, this must change. But it's not just about the strength of our economy. It's also vital for the quality of life of these beneficiaries. For people living with disabilities, CMS has long believed that meaningful work is essential to their economic self-sufficiency, self-esteem, well-being, and improving their health. Why would we not believe the same is true for working-aged, able-bodied Medicaid enrollees? Believing that community engagement requirements do not support or promote the objectives of Medicaid is a tragic example of the soft bigotry of low expectations consistently espoused by the prior administration. Those days are over. We owe our fellow citizens more than just handing them a Medicaid card. We owe a card with care, and more importantly, a card with hope. Hope that they can achieve a better future for themselves and their families. Hope that they can one day break the chains of generational poverty and no longer need public assistance. And the hope that every American, no matter their race, creed, or origin, can reach their highest potential. We will approve proposals that accomplish this goal. Ultimately, Medicaid laws need to change so that states don't need permission from CMS to develop unique and innovative solutions. Initiatives that restructure Medicaid away from an open-ended entitlement to a more fiscally secure program will allow all of us to move away from the back-and-forth negotiations between states and CMS over waivers, plan changes, and expenses, to a collective focus on improving health outcomes for the people we serve and preserving the program for future generations. But until the law changes, I am proud to announce we are taking action through a number of changes that make it easier than ever before for states to design innovative approaches to improving quality, lowering cost, and delivering value to our beneficiaries. We will begin the review of every proposal by clearly defining timelines so we can hold each other accountable and we can both plan effectively. We will move to fast-track approvals for certain routine or prior approved proposals. And for the first time in CMS history, we will approve some waivers for a period of up to 10 years if they are shown to be successful. This will relieve the burden of states to come back to CMS time and time again, increasing administrative costs for taxpayers and detracting from our focus from improving the health outcomes of beneficiaries. We are also minimizing the administrative burden on states by reducing the onerous amount of waiver reporting that has been required in the past. We need data, but we'll only ask states for what is essential. We are making innovation easier. If we approve an idea in one state and another state wants to do the same thing, we will expedite those approvals. Now, we won't approve every idea. The law will be our guideposts, and we will ensure that proposals will not result in additional cost for taxpayers. CMS is also going to roll back burdensome regulations that the federal government has imposed on states. We will focus on modifying regulations that dictate processes, but that don't meaningfully contribute to improving outcomes for beneficiaries. And we will start this effort beginning with both the managed care and access rules. Medicaid must also be flexible enough to allow for states to respond quickly to emerging health threats. Today, drug overdose is the leading cause of death among people under 50. This is a national tragedy. Many of us, including myself, had friends and neighbors fall victim to this crisis. And in response to this, President Trump has asked HHS to declare a national public health emergency and has directed all federal agencies to take swift action to respond to this crisis. In response, CMS released new guidance to increase access to treatment for Medicaid beneficiaries. We are expediting states' ability to respond to this epidemic by allowing them to unlock critical residential services for Americans with substance use disorder. We are waiving the 1970s era law that prevented Medicaid beneficiaries from receiving treatment for substance use in certain settings. Currently, many individuals are desperately waiting for treatment, and now we can give states immediate freedom and resources to unlock new treatment options and ultimately save lives. Now, the previous administration allowed this pathway, but they created onerous upfront requirements, a hill to climb, that ultimately were a barrier to states trying to respond to the growing epidemic. Only 4 states gained approval during the prior administration. In contrast, we have already approved waivers in New Jersey and Utah, and many more approvals are coming in the following weeks. Another area greatly needing improvement is the process for reviewing and approving state plan amendments, which are routine changes a state wants to make to their programs. When I came to CMS, I inherited over 300 state requests, some of them as old as 8 years. This is unacceptable, unacceptable. And we are taking swift action to correct this. Our improvements will result in faster processing and a strategy to reduce the current backlog of unresolved state requests. And so now it's up to you, the states, to put your innovative ideas into practice. We very much look forward to your proposals and helping you implement successful initiatives that improve the health and lives of the diverse set of beneficiaries you serve. And on to our second area, accountability. With this new era of flexibility, however, must also come a new era of accountability. For all those depending on Medicaid, CMS must be a good steward of the program. Otherwise, we won't be able to help our neediest citizens either now or in the future. While we will support you with increased flexibility and reduced regulations, we will also hold you accountable for achieving positive outcomes. Waivers will require strong evaluation components so we can understand the impact on recipients, duplicate best practices, and identify areas needing improvement. As long as I am CMS Administrator, you will hear that we have a higher purpose than just funding health care. We owe it to our beneficiaries to make sure that our spending produces tangible results. Medicaid serves nearly 75 million Americans at a cost of over $558 billion per year to taxpayers. And despite that spending, we have wide disparity between states when it comes to health care spending, some appropriate and some not. We need to ask serious questions about a system that, according to the Kaiser Family Foundation report earlier this year, allows one state to spend nearly $45,000 per person to care for the same category of enrollee that it costs another state less than $9,000. We need greater accountability and transparency to find out why this disparity exists. If we are all going to work together to make Medicaid a more sustainable program. Medicaid also covers approximately half of the babies born in this country. And with such a large impact on our next generation of Americans, it is vital that we track birth outcomes. We should be able to assess our impact. How many Medicaid babies are thriving due to the early interventions that you've designed, but also how many children are born with an addiction or other health challenge, so that we can find ways to help mothers deliver healthy babies and give the next generation the start in life that they deserve. We not only owe it to the beneficiaries we serve, both young and old, but to the taxpayers funding them to make sure that our investments are actually producing positive health outcomes and helping our recipients lead better, more independent lives. And to this end, I am proud to announce that we are creating the first ever state-by-state Medicaid and CHIP scorecard. This is a historic opportunity to transition from merely following federal rules and processes to focusing on achieving positive health outcomes, tangible results that will improve the lives of our beneficiaries. The scorecard will allow us to demonstrate your progress to the nation and allow others the opportunity to learn from your successes. The scorecard just isn't for states, but also for CMS, because good partners hold each other accountable. The public deserves transparency from us. They deserve to know if we're spending their hard-earned tax dollars appropriately, and our beneficiaries deserve to know if the $558 billion spent on Medicaid is producing positive results. But for this to be possible, it's critical that we have timely, accurate, and complete data that allows us to tell the whole story, your story. You are doing amazing work that should be talked about, debated, and replicated. We now have 48 states that are live and reporting a more complete data set to CMS. And we will work with you in the coming months to onboard the remaining states and ensure that this data is accurate and of high quality. I ask that you commit yourselves and your resources to join us in this effort, as meaningful data collection is an important priority for CMS and this administration. I truly believe that the data we collect and report through our scorecard will lead to a stronger, more sustainable, and accountable Medicaid program. And now to our third area, program integrity. Medicaid is a vital part of our social safety net, and we must ensure the sustainability of Medicaid by stopping waste, fraud, and abuse. And many of you in this room have been leading the charge on this at the state level, and we are committed to providing more resources to help in this effort. The examples are endless. One is a medical supply store that was fraudulently billing Medicaid for equipment that never made it to patients. In January, a physician in New York was convicted for helping to fuel the opioid epidemic by selling prescriptions for pain medications, authorizing his staff to issue prescriptions for controlled substances, and falsifying medical records. We will partner with you to stop waste, fraud, and abuse. We will work with you to ensure that all of our expenditures are appropriate and our eligibility determinations are accurate and consistent with federal policies. We will work to refine budget neutrality calculations and the use of designated state health programs. As I said earlier, and will continually say, Medicaid is too vital a program to let fraud and inappropriate spending threaten it. We have a responsibility to those who depend on us to make sure the Medicaid program will be around for them and for those who might need it in the future. We have a higher purpose than just handing out Medicaid cards and being a financer of health care. Medicaid is a promise both to our beneficiaries and to the American people that fund our programs. Our promise to beneficiaries is that we will ensure that our programs address your specific needs and give you access to high-quality health care. We will not just accept the hollow victory of numbers covered, but we will dig deeper and demand more of ourselves and of you. For those unable to care for themselves, we will create sustainable programs that will always be there to provide the care you need, to provide choices, and allow you to live as independently as possible. But for those that just need a hand up, we will provide you the opportunity to take charge of your health care and assist and empower you to rise out of poverty and government dependence to create a better life for yourselves and your family. In 1964, while members of Congress from both parties were debating the creation of Medicaid, President Johnson said this: "Our aim is not only to relieve the symptoms of poverty, but to cure it, and above all, to prevent it." If we are going to live up to the promise of Medicaid, we need to do more than simply pay for health care services. And it's why we believe community engagement requirements are in the spirit of Johnson's idea. What I ask for from those of you in this room today and those that are working in Medicaid programs all across the country, join with us in creating a Medicaid system that reaches its full potential to be a force for good in American life. Local communities are the cradles of innovation, and we need your ideas. Help us create a better, stronger Medicaid program. Help us create accountability and transparency that the American people deserve to make sure that we are all doing our jobs. I would like to invite everybody here today who have fought the political health care battles over the last decade to take a deep breath, exhale, and agree to reset as a group. We are all here for the exact same reason. We care about the most vulnerable Americans. And while we may debate about how Medicaid should be structured and how to apply resources, the simple fact remains: we are on the same team. We are Americans working together to help Americans in need. It's not simply about providing people with a card, but with care and with hope. If we are going to be successful in confronting our present challenges and prepare for the challenges of the future, it's going to take all of us, the entire healthcare community, to come together to find creative solutions. I invite you to join us in this dialogue, and I am honored to have the opportunity to speak with you today. Thank you.
Well, thank you so much, Seema. We've got a couple of minutes left, and so I want to take advantage of those remaining minutes with you here. I very much appreciate you coming and laying out the administration's or your vision for a Medicaid program. You've certainly given us all a lot to think about, a lot to chew on. I've got some thoughts, I've got some questions. I guess I will take the prerogative of the moderator, sort of maybe perhaps just reflect a little as I think about kind of some of the reactions that I know people are thinking about here. And you've given us a lot that many of us are going to say, absolutely, this is absolutely the right direction. This is a good thing. And I think about things like the commitment to the beneficiary. Which is absolutely the right way to be thinking about things. And in fact, we have a terrific session planned later today to hear from the members about their experience in Medicaid and what we're doing well and what we can improve. I think people will very much resonate with the concept of trying to focus on outcomes as opposed to process. I think that's terrific. Resetting the state-federal partnership. I think our folks very, very much agree that it is time for a reset, and it's time to think about how states and the feds can work together to focus on improvement. And the concept that I heard you say about strengthening and empowering states to approach and address the reforms that are necessary in the individual states. I think there's very much a strong resonance with that. But I do think that I would also reflect and channel some folks who may say, well, but please keep in mind a bunch of other things, including, we do not just sort of stop and say we are taking credit for coverage. What you will see, I think, throughout the states, throughout this room, is a deeply passionate, fiery commitment to improving quality, to the consumer experience, to outcomes. And I don't think there's anyone here who would say we're happy just with coverage numbers, that is a means, in fact, to an end. And that one of the things I think that has really exemplified what Medicaid has become and has grown over the many years since 1964 is that, yes, 50 years ago, Medicaid was a passive bill payer. Mm-hmm. But we have transformed Medicaid into becoming an active purchaser of health. And it looks different in every state, but that is the motivation. And I do want that to be acknowledged, and I think there's a fiery, like I said, passionate commitment to that, and one in which I think we do agree with that, and I want to make sure that we are working together on that. Because these folks are very, very committed to improving the health experience of everybody that we serve. So in the remaining just couple minutes left, I know I wanted to get your reaction to a couple of quick points. And you had referenced healthcare expenditures. One of the things we keep hearing from our members is one of the biggest cost drivers in every state is prescription drug expenditures. Mm-hmm. And that's the one thing that states can't quite seem to keep a handle on. What are you doing, or what can you do to help states in Medicaid, but also in Medicare, approach this, address this, and grapple with prescription drug coverage and pricing policies.
Well, Matt, before I answer that, let me go back a step to what you were talking about in terms of the focus of the Medicaid program and coverage. And so let me just, in terms of what I said earlier, I think that as we've expanded the Medicaid program and we've put able-bodied adults, there are many states that it's an insurance program and it's about coverage, and I think we all believe in coverage. But I think the program can be designed in a way that for these low-income individuals that are living near poverty to do more for them. It's not just about providing them insurance coverage, but these are folks that are living in poverty or close to poverty. And how can we help them achieve self-sufficiency? And how can we design the program to work that way? I mean, it's easy. It's very easy to hand them a card. But it takes another step to say, how can we truly help these individuals? And that's where I'm getting at with the program. That we don't, it's easy to pay claims and bills. And I think the Medicaid program has done a great job over the past few years with value-based purchasing and all kinds of different things to really be a force in the healthcare system. So I hope we can do more of that.
Absolutely.
But going back to your question about prescription drug issues and the cost of that for states, this is a big challenge for our nation. And I think we've all heard the president say that he's very concerned about this. And as I travel across the country and talking to our Medicare beneficiaries, and just many people across the nation, this is something that people are very, very concerned about. And with the structure of a lot of our healthcare programs, and people are paying higher deductibles, it's something that they're feeling when they go to the pharmacy to get their drugs. And I think the challenge in Medicaid is very different than I think other insurers and that people are facing. Is that because of our state budgets, we can't control, we have a very set budget. And so what we've seen is as new drugs are coming out, and I think the best example of this is the hepatitis C drugs that came out. That was, actually provided an opportunity to cure people, and we actually saw that over time healthcare expenditures went down as people didn't need dialysis treatment and they were cured of their disease. But the challenge for states in the short term was that they didn't know, and all of a sudden this drug comes out and it's very expensive, and they have to pay for it right away. And so there are a lot of challenges with that. And so as we've been talking to manufacturers about this and states, we're very much aware of this issue. And one of the things that we're exploring is value-based payment and reimbursement strategies. We recently put out a request for information from our Centers for Medicare and Medicaid Innovation because we're looking for new ways. Some of the new drugs that came out, I think I heard about one that had a price tag of $475,000. And so for a state to have to pay that would be devastating to their budget. So we need to figure out different ways of doing this. One of the things that we're doing is we are actually convening a group of Medicaid directors about how we can work on this issue. And I think that there may be some opportunities with value-based payment policies to deal with this. Many of the manufacturers are very interested in paying for drugs, maybe only if they work, so if they can demonstrate specific outcomes. And it may be possible to think about how we pay for those drugs. Maybe we're not paying for them, a one-time cost. Maybe we're paying for them over time. So I think that this is something that we all need to work together on. There are no magic bullets on this. We have to balance innovation that's coming out from manufacturers with the practical realities of having to pay for it and making sure that people have access to medications.
Fantastic. I think that is new. That is good news to our ears. That's music to our ears. I think that's, and I like, certainly as I look out there, the interest in value-based purchasing, whether it's on the prescription drug side or the acute care side or the long-term care side, behavioral health side, it's easier said than done, but it's so critical and it's so important, and it's part of what we need to be doing. And in fact, we will be, we're already working on our response to the RFI, and I hope we can continue to work on improving that. We have exceeded our time, and I want to be responsive and respectful of not keeping you here all day, because I could keep you here all day and talk about this.
And I would love to talk about it all day, but I know there's other speakers and other agenda items.
So I would say, again, thank you for coming. We appreciate your vision. We appreciate your passion. We appreciate your leadership, and I appreciate my mics going out. So if I can ask, there we go. Thank you. If I can ask you all to, again, a big round of applause.